Hello again. Happy Friday. WebCME wants you to start your weekend with a win. The Clinical Connection Friday feature is Case of the Week. Oftentimes, we are asked to evaluate patients that have stalled in their healing or, worse yet, are in a scenario of deterioration and are at risk for limb loss. Typically, these patients arrive to us with prior diagnostic and interventional efforts. This case illustrates several relevant clinical concepts, but the primary take-home message is that you should never blindly trust the report that the patient has been optimized and that nothing else can be done. This case presentation is that of a 63-year-old insulin-dependent diabetic who had a 2-month history of a plantar diabetic foot ulcer that became infected. He presented to the emergency department an extremis septic foot and severe infection. The patient was admitted to the hospital for aggressive care, including IV antibiotics and surgical debridement. 5 days following his open transmetatarsal amputation, the patient was referred to the wound care center after the surgeon said he was deteriorating. You can see on his initial presentation to the wound care center that he had extensive tissue loss and advancing tissue necrosis. The patient was sent to us as being vascularly optimized, no other potential for intervention from a vascular standpoint. We didn't trust that opinion and we started over. We started with our own assessment. We started with transcutaneous oximetry. And interesting enough, the patient had single digits on room air and didn't augment well on oxygen at all, suggesting that there was room for additional vascular improvement. Patient was taken back to the cath lab and in fact had an intervention below the knee. After maximizing him from a vascular standpoint, we then went to work, and that therapy included aggressive hyperbaric oxygen therapy, negative pressure wound therapy, and really a full court wound care press. Over time, the patient showed evidence of improvement. You can see the wound is granulating nicely. However, if you were to run your hand over this part of the wound, you would notice that there is exposed bone. The patient required additional aggressive effort to manage that exposed bone process. And we did this by implantation of an allograft. Here you see a mesh graft was placed over the wound, and over the next few weeks with continued negative pressure therapy and additional hyperbaric therapy, that graft began to incorporate very nicely, as you'll see here. The excellent take of the graft and a well-developed granulation wound base through that matrix. Once we had covered the exposed bone, the patient was then ready for split-thickness skin graft, was taken back to the operating room. Hyperbaric and negative pressure were continued for a few more days until that graft showed a good take and maturation. Patient was then followed for the next several weeks. As you can see, had very nice take, 100% take of the graft with the maturation that showed very nice progress. Once we got to this point, the idea is not to forget that the patient needs to be continued to be aggressively protected and offloaded. He was fitted with a prosthesis and was able to leave the hospital in an ambulatory state. Patient maintained this state for the next several years and returned to us on a yearly basis to deliver a Christmas present to show his appreciation. You'll notice that the patient has also has already lost his left leg previously to a below-knee amputation and was at significant risk for a loss of his right limb. Again, with aggressive efforts, these patients can be salvaged and maintained for a long period of time. But the bottom line here is start with your own assessment, start from scratch, don't trust other evaluations that can lead you down the wrong path. Well, that's this week's win. We hope this clinical correlation will enhance your wound care practice. Be sure to send us your questions and follow us on Facebook, Twitter, or LinkedIn. Enjoy a safe and relaxing weekend.